we probably want to open the floor for questions. Is that?
Yeah, I'm going to get the microphones and try to run around.
I just wanted to ask about the treatments for viruses and bacteria. The people who treated with this,
Can you speak louder, please?
for this treatment, you are just mentioning, are people treated for a while and taken off of it, and treated for a while and taken off of it, according to the numbers?
You don't. What are we treating? What are we treating with?
The treatment with the probiotics.
Yes. Well, we don't. The probiotic treatment it's fine to use probiotics in general to help gut function and improve microbiome toxicity. And we've been using probiotics for 20 years. This is a special probiotic designed by a professor in Italy to create GcMAF out of colostrum GC protein. And what that does is it is a whole order of magnitude different than a probiotic, because you're actually regulating the immune system, particularly in the gut where 80% of the immune system lies. And what we're using the probiotic GcMAF to do is to downregulate high nagalase activity. That's what we're using it for. Because if someone has a high nagalase activity, they're incapable of controlling viruses and bugs and bacteria and fungi and parasites, etc. Their immune system is incompetent. They're also incapable of killing cancer cells. So we use probiotic GcMAF to bring the nagalase down into slightly elevated levels, because when we took it into the normal range, or even low, they blew up. So when we get them down to slightly elevated, we pull them off. Now we may continue to use probiotics, but not this probiotic. This is a special probiotic. This is not something you get at the grocery store. No.
Dr. Cheney, which lab do you use to test the nagalase?
Yes, it's tested at a laboratory. It used to be called Lyme Diagnostics Laboratory in Perth Amboy, New Jersey. It has a different name now, but it's connected with the European Laboratory of Nutrition. The director of this laboratory is a professor at NYU. Wonderful, wonderful man, brilliant scientist, the top scientist at Johnson & Johnson's for 20 years. He finally got burned out in corporate America, and he became a professor at NYU in biochemistry. But he has developed a lot of the tests at this laboratory that we have most enjoyed employing, because unlike a lot of laboratory pathologists and biochemists, he's really a scientist at heart, and he's a very good one. So we do a lot of testing in that laboratory. We do all the SOD testing, GPX testing, methylation block testing, NADPH testing, SOD, GPX, catalase, nagalase activity, a lot of testing in their labs because they're very good.
Can you tell us when GcMAF will be available for?
When what?
When the GcMAF will be available?
Well, you can. GcMAF is available from Europe now. You can actually go on the internet and buy GcMAF from the UK. You can buy it from the Netherlands. You can buy it from Israel. You can buy it from a lot of places, but you can't buy it from the United States. Now, that's problematic because physicians are not allowed to administer GcMAF, so you sort of have to get it yourself. But there are loopholes that allow physicians to follow patients who choose to use it. We have sort of gotten a little bit away from chemical GcMAF because probiotic GcMAF, I think, is better. It's more natural. You're not using a blood product. You don't depend on some laboratory in Europe. You just mix up yogurt and kefir in your own kitchen. It's a lot cheaper. It works better. Now there is you can purchase the ferment for this special yogurt. You can purchase the ferment from this special kefir from an online source developed by Dr. Ruggiero from Italy. I had nothing to do with this. He just set it up independently to help doctors interested in using probiotic GcMAF of all stripes. There are physicians at cancer clinics that are integrating it into their cancer therapy. There are clinics that are integrated into HIV therapy. There are clinics such as mine that have integrated it into chronic fatigue syndrome. But the danger of this is, as I mentioned, you have to be very careful with this. And if NAGLase is high, you can defend using it for a period of time. As NAGLase starts to come down into the low, slightly elevated range, you need to get off of it. If you keep driving NAGLase all the way into low level, we typically see a reversal of clinical response. People start getting sicker.
I have a question.
We have a question.
My question is, why I appreciate all of your education. I appreciate all of the experiments that you have done, but an average person cannot afford your fees.
Understand. Well, what shall I say? The problem with chronic fatigue syndrome patients is that they take hours and hours and hours of meeting and dealing with them. You might ask how many patients I see a day. I see one patient per day, and I see them almost all day long. So what happens is, when you see a physician who spends almost the entire day with you, I have to load the cost of the clinic onto your shoulders. I can't see 30 or 40 people. If I could, the expense would be low to you, but you would get exactly nothing.
Amen.
That's the reason. If you think about it, like I went to my dermatologist recently. I calculated that he was charging me $3,000 an hour. I'm not charging you anywhere like that. I'm pretty modest on an hourly basis, but I spend 3 or 4 or 5 hours with you. And I only charge for my time. I don't charge for anything else. It's just between my ears. And just when I'm facing you, and when you leave, I don't charge you anymore. And I order very few tests. People don't walk into my clinic and spend $15,000 on tests. I don't do that. So I think when we did a cost analysis of how we do, I think we're actually relatively inexpensive when amortized over an entire year, because you see us for 4 or 5 hours per year, and that's about it.
Okay, I was not aware of that. Most doctors want you to keep coming back every 6 weeks, every month.
I see most people are seen once a year. Sometimes we'll have a short phone call, sometimes a short email for contact, but they're generally seen annually. So if you amortize my hourly costs for 3 or 4 hours times 1 year, we're really cheap.
You are really cheap. Thank you for clearing that up for me.
Yes, I have been diagnosed with both fibromyalgia and the chronic fatigue syndrome. When do I tell the difference between the two? Such as, I look at mine, if I overdo it, and when I say overdo it, if we go out of town and see our grandchildren as a fun activity, and they were just gone overnight, it may take me a week to get over that.
Then you have chronic fatigue syndrome.
But then how do you say, okay, that's the chronic fatigue syndrome coming through, or how do I know when it's just fibromyalgia?
I don't really spend too much time on what you have. I listen to see if you sound like a CFS patient, with or without complicating fibromyalgia. The best treatment for fibromyalgia and chronic fatigue syndrome is to address the sleep disturbance. It is the absolute best way to treat fibromyalgia in this syndrome. Now, that is not easy, I might add. Sleep disturbance is a big deal in chronic fatigue syndrome. And it could be the refluxing of the cerebral vessels has a great deal to do with the sleep disturbance. But we learned right away that if we couldn't get our patients to sleep well, nothing else will help, especially fibromyalgia gets worse. So magnesium is also wonderful for fibromyalgia. So there are a couple of things that we do inherent to the treatment of chronic fatigue syndrome that, quite frankly, makes fibromyalgia not a big deal. It doesn't become a complicating factor after a while.
Simple question: who should come to your clinic And as a physician, I'm a pediatrician, how come physicians don't believe that this is real?
Some do. Are you saying a statement or a question?
You know, a lot of them don't seem to put much stock in it.
Well, you know, it's if you usually they don't know much about it. It's a shame that they will pontificate an opinion when they haven't studied the subject. So I see a lot of physicians in the scientific meetings that I go to all over the world. Literally hundreds of physicians are in the audience, and they all believe in this disease because they're studying it. And the only time I see physicians that don't believe it exists or pontificate about it or give an opinion about it, you don't have to drill down too far to find out they know absolutely nothing about it. So I wouldn't worry about that particularly. That bother me, shouldn't bother you. If they don't know anything about it, then they just should, I don't know that they should give an opinion about what they don't know and study. But that's not true about the physicians that I know of.
But who should come to your clinic?
I'm sorry, who?
Who, yeah.
Well, we see people from all over the world.
But who think they have chronic fatigue syndrome or fibromyalgia or both?
Well, I see both. I've seen both. I tend to, fibromyalgia is really easy to treat, in my opinion. And as time has gone on, it's become a smaller and smaller and smaller fraction of my practice. And as I said before, I don't know if it's because I'm selecting out CFS patients and deselecting fibromyalgia, or whether, which I suspect more likely, fibromyalgia patients tend to get gradually better. A lot of them, they don't get super sick, and I tend to see the super sick people. And also, our therapeutic approaches tend to work pretty well in fibromyalgia, so after a while, I'm not really dealing with that particular problem. So I don't worry too much about the name. I do kind of listen for the drumbeat. My brain isn't working like it used to, and I have these processing difficulties. And when I push myself, I crash and burn. That's all I need to hear. Whether they have fibromyalgia, whether that makes no difference to me, because at that point, we're dealing with a chronic fatigue syndrome patient, with or without fibromyalgia. Conversely, if I see someone says, well, you know, I don't sleep very well, I'm fatigued a lot, and I hurt, but my brain is perfect. And when I have to go to work, I can, and I don't crash and burn. That's not chronic fatigue syndrome, that's just fibromyalgia. It's a much easier thing to treat.
Doctor, where does Lyme disease fit into this whole picture?
Very, very nice question. I'm not exactly sure, is the bottom line, but I'll give you an idea. It's not necessarily the idea, but it's an idea. I met some Lyme doctors. In fact, I belong to an email listserv of about 80 clinicians from 4 continents. And quite a few of them are Lyme experts, and some of them are the best Lyme disease doctors in the world. And one of them, whom I respect the most, an excellent physician in Long Island, was actually one of the people that actually described chronic Lyme disease initially. And I was talking to him, and he told me that he saw acute Lyme disease in the Long Island area for a decade, between 1970 and 1980. They would get a tick bite, they'd get bullseye rash, they'd get arthritis. He put them on doxycycline, and they would get over it. Sometimes they get a tick bite, bullseye rash, and arthritis, and they weren't even treated, and they got over it. And he said that was the way it was for a decade, for 10 years, and this is important. He said, and I never saw a single case of chronic Lyme disease between 1970 and 1980, not one. Then, in 1980, which is when this CFS epidemic seems to have erupted in the major cities of San Francisco and New York City, he began to see people get a tick bite and bullseye rash, acute Lyme, but now when he treated them, they didn't get better. And they went on to develop what he would call chronic Lyme disease. Studies at NYU and SUNY Downstate and other places, comparing classic Lyme cases to classic CFS, cannot find any clinical difference between them. Furthermore, the P41 band, important in the diagnosis of Western blot of Lyme disease, is also the early antigen of HHV6. It's also the envelope protein of the HERV, HERV, that I just showed you. So if you remove the P41 band from counting, very few people will ever meet the diagnosis of chronic Lyme disease. So I have a feeling that why Borrelia may be involved in some people, I have a sneaky feeling that Borrelia, that chronic Lyme and chronic fatigue syndrome are exactly the same thing. That's my opinion. Of course, I have a skewed view of this because you understand that I'm the one that sees chronic Lyme patients who went to numerous Lyme doctors and have been treated for years and years with potent multi-spectrum antibiotics and failed therapy, and they end up at my door. And when I look at them with all this technology, they have chronic fatigue syndrome. So I'm not, I'd hesitate to say that Lyme doesn't exist. I think it does, and it causes acute disease. I'm not sure that it causes chronic illness, because it never did.
You were talking about the symptom of, I do something because I really want to do it, and then I crash and burn. Is that basically pathognomonic, or does that happen with other diseases you're familiar with?
You know, it's very interesting. There are a lot of diseases that have chronic fatigue. In fact, most chronic illnesses have an element of chronic fatigue. But often in those diseases, people push through it. My patients will do minimal effort, like just walking across the room, or they'll fix dinner and they'll have stood too long, and they're wiped out for days just doing this minimal effort. And I don't know of another disease that looks quite like that, but which also demonstrates severe cognitive derangement and abnormal neurological findings, and has some of these other features I've been talking about. So I think, I suppose you could probably find someone who has a push crash phenomena for some reason and may not have chronic fatigue syndrome, but that is so characteristic of this disease. And when you add in the other elements, the cognitive complaints and neurological findings, that's chronic fatigue syndrome. And I'm pretty confident of that.
I guess my question is, with some of the things you talked about with the heart and even with standing being a problem, and then with the fatigue, what would you say is a good way to balance whether or not to exercise if it's like more detrimental with these factors?
Yes. The one advice I would have is do not rationalize exercise. The rationalization of exercise goes something like this. I'm going to get up and I'm going to walk a mile on Monday, and then 2 miles on Wednesday, and 3 miles on... That's called rationalization of an exercise program. That doesn't work in this illness. What tends to work is, I'm going to walk around the house today and then ask the question the next day whether I did okay. And if I did, maybe I'll advance a little bit, and then ask the question, am I all right? And sometimes it's not quite evident whether you overextended or didn't at the time, but you kind of begin to internalize a sense of self. I think this is helping me at some deep level. I almost intuit it. And when you start going from your brain, thinking about exercise, to feeling what it's doing, then you start to exercise correctly. And there are several good exercises for this disease. The best exercise I know of that's simple and inexpensive is simply to walk. Walking on flat ground, try to do it every day if you can, but not too far, as much as you can, but not overdo it, is best, because a human being is designed to walk very efficiently. And when we walk, our legs are squeezing blood, so we actually pump blood back up and out, so you actually fill the heart. So people do pretty well when they walk. They don't have to walk fast, just walk. That's very good for this disease. Pilates is excellent for this disease because you're in the supine position where you get max, remember your cardiac output goes up 30% when you're laying down. And just do gentle types of exercise.
Well, don't go through the whole routine like I did.
But the important thing about Pilates is to not get into the vertical position. There are vertical exercises, and Pilates is not good. Resistance is what I was trying to think of. And that's pretty good, but don't use the heavy weights, use the light ones. It's just range of motion with light resistance for very short periods of time. That seems to be good. Another one is vertical immersion in water. People will just stand in water to their neck. Believe it or not, the pressure in your body goes down as the square of the depth. So the further down you go, you get a pressure differential that pushes blood back up into the intravascular space and improves lymphatic drainage. Excellent for chronic fatigue syndrome. They don't have to do very much. They just have to float or stand vertically for an average of about 20 to 40 minutes, 3 times a week. One of the best things I've done, I think the mobilization of lymphatic fluid is an immune modulator for these patients. But it's functionally difficult sometimes for patients to get to the pool, logistically difficult, or the water temperature isn't right. So walking and Pilates, what is not good is running, bicycling, or significant aerobic activity. That's not good for these people. They don't fare well. Resistance training is a little better tolerated. It isn't too much of it. So don't be rational in exercise. Be intuitive in exercise. Don't overdo it, but do something.
Thank you.
Dr. Cheney, what about I am cold, just really cold all the time?
Yes.
And how's that with the thyroid? Getting it right?
Very good question. The thyroid's interesting. You remember I talked about the body adapts to a low energy state? It has to, because if it tries to stay in a high energy state, it generates too much oxidative stress, which is deadly. So it adapts to a low energy state. How do you think the body creates a low metabolic rate? The answer is it downregulates thyroid function. So the low thyroid function, get this, is not the problem, it's the solution. And the way you can tell that is if you look at the TSH level, which comes from the brain, it's generally very low. It's down around 0. And then you'll see low thyroid hormone in the body, but you'll see a low TSH. That's the body down-regulating to a low metabolic rate. That's not thyroid disease. So what we find is we're very careful about treating thyroid. In fact, often I try to resist treating thyroid. I try to assess whether they really are hypothyroid, suggested by high TSH, which I almost never see, or whether they're down-regulated to a lower metabolic rate. And admittedly, that's going to produce stuff like being cold, because that's what it's like to be in a low metabolic rate. But you may think about how we treat heart attacks and strokes these days. What do? We pack them in ice. We do that, we produce less damage. It may be that what you're doing is down-regulating to a lower energy state to save your life. That's manifest by a low metabolic rate and feeling cold, but it is, believe me, not your problem. Exceptions do occur. If your TSH is 30, then yes, you need to be treated with thyroid. But if it's 0, I would never touch you with thyroid, even if you were hypothyroid.
So should I take my medication or not?
I'm not your doctor, I have no idea.
No, I understand. It's just...
Yeah, there's a sort of story, a larger story in this disease. Physicians are taught to draw blood and react to it. So what we think is that when someone's blood's out of range, that's bad, and we need to bring it in range. Never do we think sometimes that sometimes blood is out of range for a reason for that person. The body is adapting to some deeper issue. And I've learned this in chronic fatigue syndrome over and over and over. I try not to react to blood tests, because often those blood tests are simply compensatory mechanisms at work, And if you try to address that, you make them worse, not better. So that's worked a lot better than to attack abnormal blood tests. Admittedly, I do this in the context of chronic fatigue syndrome, not in the context of some other diseases where you might legitimately react to blood tests. Because I believe these people, typically they go for decades relatively stable. They don't die in mass. They don't degenerate in mass. When they die, you autopsy them. The autopsy is normal. So they seem to be compensating. So why should I intervene with a lab test, which may be part of their compensation scheme? And that's especially true with thyroid.
Okay, I have a question back here. Magnesium, you said the tablets would not help with this. You was talking about rubbing it in.
Yes. Magnesium is probably the simplest, cheapest, best thing to ever take for CFS. Well, it's in different forms. You can. It's available from Kirkman's laboratory as a paste. It's excellent, and you just dip your fingers in the paste and you rub it on your arm, and you're getting magnesium in your body in very short order. It's relatively inexpensive. I have people take the bottle, the paste, and put it behind their pillow or bed rest, and if they wake up in the middle of the night, they'll just reach back and open it up, dip their fingers in, and rub the paste on their forehead and their back of their neck, and they'll fall right back asleep. If they hurt somewhere, they just rub it in to where it hurts. It's just really excellent. It's very cheap, inexpensive, and works very well. But it doesn't last very long. It may only last for a few hours. There's also sprays that you can spray under your tongue. That's excellent, especially for panic attacks and anxiety disorders and muscle cramps. And finally, probably the most effective of all is an injection. And I teach my patients to self-inject 0.1 cc of magnesium sulfate in the leg, and they can do it once or twice or thrice a day. That's a very tiny injection, and that lasts about 4 to 6 hours.
And you take this for...
And they can take it every 4 to 6 hours. There's no way you can overdose on this unless you have renal disease, because you're leaking magnesium constantly out of the cell and you're pissing it out in the urine, and you can't correct it because it's not a nutritional problem. It's an energy-related phenomenon. All you can do is try to keep up with the losses on a very regular and consistent basis.
We have time for 2 more questions, and then we are going to have to draw this to an end. We have to be out here about 10 o'clock.
Dr. Cheney, when would you recommend that a patient get a second opinion?
Good one.
A second opinion. If they've been sick for a couple of years and they've been in treatment for 8 months and they're not getting any better, it's a time for a second opinion.
You mean if they think they have chronic fatigue syndrome or something else?
I believe I've been told they have chronic fatigue, and I believe I have it.
Yeah. Well, it's ultimately the patient's decision about whether they think the doctor's doing all that he can to help. And if he's not helping, he may be missing something. You may be a treatment-resistant case. They do occur. And no matter who you went to, they wouldn't do much better. But I just don't have a flavor for the physician you're seeing, but I'll simply say that I fail also. I have patients that don't respond. But what I try to do is that I don't give up on them. We just keep trying. If this doesn't work, we'll do something else. And if this isn't working, and I just keep trying in different approaches. And my sense is, as long as I'm trying to as hard as I can, and I won't give up on them, then they're happy that they may not be responding. When you get a sense that the physician just doesn't really care anymore, or he can't think of anything, he just would rather you not come, that's the time to move on.
Thank you.
I have a question. You mentioned the research that's going on in Europe. Is there other research that's going on in the United States, because our research dollars are declining, and it seems more and more research is occurring in Europe?
Yeah.
Should we be looking there?
Well, Yes, there are research efforts in the U.S. One large grant was just given to Dr. Shingu at Cornell Weill based upon his MRSI scan work, and he's collaborating with a number of clinics in the New York City area. That could be a very important group that's emerging, and I don't know how many millions of dollars they were given just recently. That's going to be an area to watch in New York City. There are probably other areas as well, but you're right, that research dollars for chronic fatigue syndrome does not match the severity of this problem and the numbers of afflicted and the economic costs. It's just simply, it doesn't get the respect of other diseases, and there's a long and complicated history behind that.
Also, the tests that you mentioned, the Nagalase test and so forth, are any of those reimbursed by anybody or a research project?
There are some tests that are compensated, especially those done at the major labs like LabCorp and Quest, of which there are some tests done there. But what I found is that these specialty laboratories that specialize in niche laboratory work, usually insurance doesn't cover that. The good news is that the cost for a Nagalase test is $65. So a lot of these tests are not terribly expensive.
Thank you very much.
We have one question about you, children.
Children?
Yes.
I just wanted to ask, my daughter was diagnosed with chronic fatigue at age 14, and we were told that she had a normal MRI, and I know you mentioned the ventricular lactate being elevated.
Yes.
I don't know how do you
do that?
find that?
Yeah, I would have her done at Cornell Weill Medical Center on the east side of Manhattan by Dr. Shingo. He is a wonderful scientist. He's from Nigeria, but he's wonderful and really believes in this disease and has been doing MRSI scans on the brains of CFIS patients since 2005, so a period of 8 years. And he got the largest grant from the NIH to do this work of anyone that I know of. So I only send patients to him. I don't send patients to anyone else. And by the way, they have a study going on, and that if you're willing to be in the study, they'll do the MRSI for free.
Okay. Do you have anything to add about teenagers with chronic
there are two vulnerable periods for the development of chronic fatigue syndrome. One is around puberty. And young girls are particularly vulnerable, but sometimes boys as well. So around puberty is when you'll see this disease hit. In the case of females, the hormonal shifts that occur in puberty are dragging the immune system up and down with their cycle. And so it tends to be pro-inflammatory. It tends to it feeds this disease, and there's a vulnerability spike in terms of when people get this disease. Another spike tends to occur, for some reason, in the 30s. Often when people are just hitting their stride and are really working hard and their careers are blossoming and they are at their peak physical condition, and then wham. I don't see a lot of this disease developing in elderly populations de novo. I don't see a lot of it in children under the age of 10. There are physicians that do, but I don't, so I can't speak much to that. But I do see spikes in the puberty pubescent teenager and in the young adult. That's where the two big spikes occur. It falls off in the older crowd and falls off in the children. And there probably is a good explanation for that. I've mentioned one of them, but that's just what we see. Children, by the way, although they can be very, very ill, I've seen them, their prognosis is much better than the adults. So often, if children are correctly treated, they do rather well, most of them.